Good morning, everybody, or good evening, wherever you are in the world. Can everyone hear me okay?
Yeah.
Yes.
Great. Yes, thank you.
Awesome. So I'd just like to say hello from GlobalSkin. My name is Nicole, and I'm the Member Services Manager here. I will be moderating today's COVID-19 Virtual Town Hall, Understanding COVID-19 and its Impacts on Dermatology Patients, with Dr. Esther Freeman. So I'm really happy that we all have this chance to connect during this global health crisis. And I know we will learn a lot from Dr. Freeman and from our discussion with one another. So I'll be covering a couple of housekeeping items before we officially start. We'll be recording this session for all future members to browse in the members only area on our website. And today's session will be about an hour or so long. Dr. Freeman will take the first 20 minutes of the session to share her experiences, and we'll have about 45 minutes for discussion. We also have folks from the ILDS providing a short presentation as well. And so to maintain bandwidth during this presentation, I know that a lot of us right now have our video and potentially our microphones on, but we will be muting all microphones and videos of participants during the presentation, just so that we can have a clear presentation from Dr. Freeman. So please feel free to use the chat pod feature at the bottom of the screen to type out any questions or comments that you might have during the presentation, and we will get to them at the very end. So at the very end, you can also unmute yourself so you can ask the questions yourselves. So we're really happy to see so many participants today. We'd love to capture a photo of you all at the end. So if you are comfortable, we will ask participants to share their screens at the very end so we can take a group photo. Finally, I would like to welcome our friends from the International League of Dermatological Societies, the ILDS, Patient Organizations Working Group representatives for today. So we have Professor Luca Boradori and Dr. Ramesh Bhatt, who I now welcome to provide a brief greeting on behalf of the ILDS.
So, hello everybody. Good morning or good evening from Switzerland. My name is Luca Boradori. I'm a professor of dermatology in Bern in Switzerland. And together with Professor Ramesh Bhatt from India, I welcome you on behalf of the International League of Dermatological Society. Today is a special webinar, and I'm very thankful to GlobalSkin and to the International Alliance of Dermatology Patients Organization for making this possible, this specific webinar about COVID-19 and the impact on on dermatological patients. And I would like just to share with you a couple of slides concerning the activity of the ILDS, which as last year has decided that the relationship with patients and patients organization is one of the priority of our organization, will be one of our priority in the next years, because we have really realized that we can move something towards better patients' care and better patients' recognitions, patients' needs, and so only by working closely together with patients' organization and with patients to better understand each other, and also to have a major impact on the policymakers about our about the needs and expectation of the patients. So Mana, do you have our slides of the International League of Dermatological Society?
I need to listen to it for a second.
That we want to show, or
Okay. Wait a sec, sorry.
yes.
Just trying to share the slide. Sorry, I'm just trying to do that now.
Nicole, you may need to unshare.
So good.
Can you see the slide now, or?
Yes.
Yes,
Yes.
Okay.
But you have to go on the first slides. you start on your first slides.
Yeah,
Sorry.
sorry.
Yeah.
Yeah, I can do it now.
That's perfect. You can move forwards, please, Somana. So the International League of Dermatological Societies is an organization which represents almost 200 dermatological associations worldwide and represents more than 200,000 dermatologists all over the world. And if we can go forward, with representation from all over the world. Our vision is try to make all possible to provide the best possible skin health for all people around the world with the motto Skin Health for the World. And our mission is to increase awareness, cooperation, communication within the dermatology community to promote education, clinical care, research, innovation, as well as having, of course, the patient's need in the center of our attention globally. Next slides. There are a number of representatives in the board of the ILDS coming from all over the world. Next slides, please. And our major areas of activity are, of course, interaction with the policymaker, with all various stakeholders. Second, we would like to represent dermatology worldwide and ensure that our project and our ideas and initiative have a certain sustainability and keep alive. And the third, but very probably the most impressive area of activity are all the projects of humanitarian dermatology that the ILDS has been supporting for years. Next slide. And these are our main area of practical working. We organize every 4 years a World Congress of Dermatology, and we really, our humanitarian initiatives and projects are ensured by the activity of the International Foundation for Dermatology, which is our arm in order to promote all these humanitarian projects. And one of our main partner, stakeholder with whom we try to move things forwards is the World Health Organization. Please, next slides. So here some areas where the ILDS is currently working. We try to improve the classification of skin diseases because this is essential in order to have the correct, proper recognition of the disease burden for the patients and having a good visibility of all the skin diseases which exist, which frequently are considered by certain colleagues not so severe and not so bothering at all. So it's so very important that we will well represent the variety of skin diseases. We, of course, try to make aware the word about neglected tropical disease. We try to improve the access to essential medicine, and we make our stakeholders aware about occupational skin diseases and other chronic diseases like psoriasis, like vitiligo, atopic dermatitis. And nowadays we also try to make clear that during aging, skin is very important. It's the biggest organ, and we have to take care of the skin in order to prevent all possible complications associated with skin aging. Last slide. And so now, with regard to the COVID-19 pandemic, which has affected at least 5 million people around the world, at least, but this is an underestimation, with approximately 400,000 deaths. But again, this is probably a huge underestimation. We are facing with a new challenge, a new disease, which we start to get more familiar, to better understand. However, there are a lot of things which need to be better known. And today's with Professor Freeman, who is going to speak on the topic. This is a way by which, as physician, we would like to better make aware patients and patients organization about at least the dermatological aspect of the coronavirus infection of the COVID-19 disease. And this belongs to our current activity, because what we want to do as ILDS is to really provide a platform where we provide information. We try to promote registries in order to have a better understanding of the characteristic of the disease. We try to provide guidelines as how to manage patients affected by the COVID infection and having at the same time a skin disease. And we try to give also simple advice as how to prevent to get infected, you know, like hand cleaning, mask, and so on. Probably last slide. So what we would like is, in the context of the COVID-19 disease, is that the ILDS has a task force with representation, with members representing all the continents. And this task force should try to provide leaflets, information concerning COVID-19, which can be used worldwide in order to better take care of patients with skin diseases. So this was the short introduction I was supposed to give on behalf of the ILDS, together with my colleagues and friend Ramesh Bhatt. And so we are very pleased to be here with you. And we also look forward hearing Professor Freeman talking about this important, so at the moment, the hottest topic, which unfortunately represent the worst catastrophe our world is facing after the Second World War. Thank you very much, Professor Esther Freeman, for your presentation and taking time for us.
Thank you so much, Professor Boradori, as well. Finally, I'd like to hand it over to Christine Janis, our CEO, to introduce Professor Dr. Esther Freeman.
Thanks so much, Nicole. So it is my great pleasure to introduce Dr. Freeman. I had the great pleasure to meet her actually at an ILDS meeting in London, where we talked about global dermatology and some of the projects that the ILDS's foundation is working on. So she is the director of global health dermatology at Massachusetts General Hospital at Harvard Medical School. She's the chair of clinical guidelines committee at the AAD, the American Academy of Dermatology, and a member of the AAD's task force on COVID-19. Which is significant. She's also the chair of GloDerm, which we talked about extensively in London, which is the International Alliance of Global Health Dermatology. Her background is she received her PhD in infectious disease epidemiology, so she couldn't be the more perfect person to talk about this. As a British Marshall Scholar at the London School of Hygiene and Tropical Medicine in the UK. And her medical degree and dermatology residency was done at Harvard Medical School. She oversees the International Dermatology COVID-19 Registry in collaboration with the AAD and working together with the ILDS, I believe. So thanks very, very much for the time today and the time that you've taken to prepare and work with us and to work on all of these projects. So we look forward to this and a very vibrant conversation today. Thank you.
Thank you so much, Christina. It's really an honor to be here with all of you. Give me 1 second as I share my screen here. That's interesting. Give me 1 sec. Where did it go? Apologies, the best for preparations, and then the last minute your presentation disappears. Give me 1 quick second. There we are. Perfect. There we go. All right. Can I get a thumbs up or a yes from somebody that they can see my screen?
Looks great.
Okay, perfect. Thank you, guys. Well, really a pleasure and an honor to be here with you this morning for me and this afternoon and evening for many of you. And it's been, a really interesting and challenging time for all of us, but a very interesting time to be in dermatology and try to really capture what's going on with the field of dermatology and COVID-19. So I join you today as a member of the American Academy of Dermatology COVID-19 Task Force, and also as the principal investigator of the combined American Academy of Dermatology and ILDS COVID-19 Dermatology Registry. And I want to talk to you a little bit about what the registry does, some of the initial kind of thoughts and findings from it, and kind of where we can go from here. So just a quick mention on my role about the American Academy of Dermatology COVID-19 Task Force. We do have an updated daily website. I'm showing you here the provider side of it. There's also a patient-facing side, but we do have a COVID-19 library of relevant documents as related to dermatology that may be of interest to you. So I just wanted to point that out. And these are actually available even if you're not a faculty member. You actually can still access the side of the website. We did post just about a little over a week ago now, the American Academy of Dermatology did make their first statement on dermatologic manifestations of COVID-19, just to make people aware that one of the manifestations can be these perennial-like lesions of the feet and hands. I'll be showing you a bunch of pictures of that. And I think one of the major points we wanted to make is really one of reassurance and not to panic. We are seeing patients with these perennial-like lesions of the feet and hand that are doing extremely, extremely well. And I really wanted to kind of reassure the public in general that if you only have purple lesions on your hands and feet, this is not a reason to go rushing into the ER. This is definitely something that can be managed at a distance. As long as, if you have another reason to go in the ER, you should. But, purple feet alone is not a reason to rush in there. So we did make a statement to that effect from the AAD just to kind of reassure people, but also just discuss the fact that you could be potentially infectious. And so having a case-by-case discussion with your physician and with your board-certified dermatologist is very helpful in these situations to figure out if COVID testing and isolation is potentially the right option for you. So we launched our registry, and I'm going to talk a little bit more about the details of this, a combined effort between the American Academy of Dermatology and the International League of Dermatologic Societies through Professor Lars French. And I'll tell you a little bit about this, but the idea here is that we are more powerful as a group. So individual providers noticing individual cases, it's very hard to see patterns, but if you really start to collect all of these cases from around the world, you can really start to see something and say something about what's going on with COVID-19 and the skin. So a big thank you to the International League of Dermatologic Societies, to the staff, and also certainly to Lars French for really helping move this forward so quickly. I think a large international collaboration like this, in my experience, could take a long time to put together, and I'll show you the timeline, but you moved pretty quickly. So what can a registry do? So it can really reach globally very fast. And the idea is that we can collect cases from a lot of different places very rapidly, and we can do that in kind of a standardized way. It's very good for generating ideas. We can start to see patterns, but it can't really tell us about causation. So the patterns that I see in the registry are not going to tell me that definitely A causes B. I'm not really going to be able to tell that from the registry. The other thing the registry can't tell us, and this I know I wish it could, and lots of people ask for this, but it can't tell us, is of everyone who gets COVID, what percentage are going to develop skin manifestations of the disease? And the truth is we don't know, because we're just seeing the cases that are reported to us, and it's not a larger epidemiologic study where we're looking at everybody. And the truth is worldwide right now, we don't even know who has COVID. Many places in the United States, we're not able to fully access testing yet. And hopefully in other places they have better access to testing, but certainly an issue that, testing is still probably not where it needs to be. So I wanted to give you a little backstory about how I think that cases and case histories and case registries can actually really impact epidemics and outbreaks. So I am normally, pre-COVID, I am an HIV researcher, HIV/AIDS researcher, and I work a lot in sub-Saharan Africa. And I'd like you to remember now, just for a moment, the spring of 1981. And there were a cluster of 5 cases that were reported to the CDC in their MMWR report of 5 otherwise healthy men who developed a very unusual form of pneumonia, Pcp pneumonia. That was published in the MMWR, which is a publication from the Centers for the Disease Control in the US. And a dermatologist working, that was from California, out in the west coast of the US. And a dermatologist in New York City the same day read that report and called the CDC and said, that's weird. I have a collection of otherwise healthy young men who have developed Kaposi sarcoma, which is an unusual cancer that we can see on the skin. And those disparate case reports that were on 2 different coasts really were the beginnings of our understandings of the HIV and AIDS epidemic. So I'd just like to point out that I think that dermatology has an important place in kind of epidemic history and outbreak history, and that case reporting and really noticing beginning signs and symptoms of things can lead you a long way. And I think back to even to Zika, where it was a dermatologist in Latin America who, not a dermatologist, excuse me, a physician in Latin America, I believe a pediatrician, who noticed that she was having a lot of babies with very small heads, and that led to understanding of the Zika outbreak. So I do think that these clinical observations are very important. So we proposed the concept to the American Academy of Dermatology Task Force back on March 30th, kind of earlier on in the epidemic, got their approval, and then very quickly programmed the database, and then got in touch with the International League of Dermatologic Societies, which provided their support on April 6th. And we were able to launch the entire registry and go live with our first cases being entered on April 8th, which is a total of 9 days from initial conception of idea to completely launching the registry with people entering data. In my experience as an epidemiologist, this normally takes about 6 months. So really a very, fast forwarded process. And I really thank the ILDS for that and the AAD for that, because I think really it's a time when people are willing to kind of break down borders and really work collaboratively to make these things happen and come together very quickly. I think everyone understands the urgency of the situation, and that's meant we were able to act very, very quickly, which has really been very helpful. And I should say also reaching across specialties. So we reached out to the International League of Rheumatology, and they had started a registry for a different purpose about probably a week or two before us. And they were very collegial in sharing their lessons learned and their challenges that we were able to build upon. So where are we now? We now have cases entered in the Dermatology COVID-19 registry from 31 different countries. And just to give you a sense of how fast this is happening, so starting about 2 days after launch, we were getting about 10 to 15 cases a day. At our peak, we were getting about 50 to 60 new cases a day. And that started to taper off a little bit. I think that kind of mirrors a little bit the epidemic curve, but we're still getting a lot of good cases. And I will say the data that we're hearing about now is much more detailed. People are getting more antibody tests. There's a lot more information that we're getting. We are now at over 700 cases, as I mentioned, from 31 different countries. We're trying to do real-time analysis, and our first publications are currently under review. I think another important thing is to talk about the concept. This is really an ILDS effort, I should say, to really harmonize different dermatology registries worldwide. And so we are certainly one registry, but there are a lot of other registries that are dealing with more disease-specific conditions. So psoriasis, atopic dermatitis, alopecia, hidradenitis suppurativa, for example. So we did work together as a group to really lay out how we could possibly collaborate, what different variables we were using that were the same or different. And the other thing I want to say about the registry is that the ILDS and the American Academy of Dermatology registry is what we call provider facing. So as a patient, you yourself cannot go in and log your symptoms. It's really meant only for medical professionals to log your case. And so you cannot log your case yourself. Some of these other registries have developed, all these registries listed here are provider facing registries. So you cannot enter your own data for any of these registries, with the exception of psoriasis and atopic dermatitis and hidradenitis suppurativa have created what's called separate patient-facing registries. So you can't enter your data into the provider registry, but you can enter your own data into the patient registry. And those questions are a little bit different. They're more geared towards you as a patient as opposed to your provider. So there are what we call patient-facing registries, and I think that's really important to capture the patient experience. So there are ways, if you do have psoriasis and you develop COVID-19, to report that in the patient-facing version, for example, of the psoriasis registry. So we have been talking a lot to the press about our early findings with the idea that this really can start to affect care and it can start to affect testing. Early on, people really were not able to get tested when they had potential dermatologic manifestations of COVID-19 because they just weren't recognized as being potentially related to COVID-19. So these are two journal articles that I've done both in the New York Times and the Washington Post talking a little bit about this. But one question I've gotten from people is, why are you talking to the press when your data is not even really out yet? You're still collecting your data. Shouldn't you really wait till it goes through peer review? And I wanted to address that question. So let me introduce you to my dad. He actually died 20 years ago this month, actually this week. And he was professor of epidemiology at Harvard School of Public Health. And he was what I like to call a kitchen table epidemiologist. So at home, over dinner table conversations, he would bring home outbreaks. not physically the germs or the virus, but he would bring home the concept of outbreaks, and my brother and I would have to solve them over dinner. So, you know, if there was an outbreak at a picnic, was it the potato salad that had been left in the sun too long? And he founded and directed for many years the outbreak course at Harvard School of Public Health and taught on that. And recently, one of his students, who's now a leader in global health epidemiology, contacted me actually towards the beginning of the epidemic. And he said, you know, I'm thinking of your dad a lot during this outbreak, and I wanted to share this quote with you from him. And this is one of the quotes from his outbreak course at Harvard School of Public Health. And so my dad said, when confronted with an outbreak, your job is to make it stop. It's such a simple statement, but I think it really gets at the core for why we need to speak with the press and be very open about what we're seeing and not wait. This is not something that we should be sharing 6 months from now. This is something we need to share now. And if we have the ability to save lives and recognize a condition that could be related to COVID-19 and potentially get that patient tested and prevent them from spreading it to a friend or a family member, that's our most important job. So I think that's kind of important to remember. Why are we doing this? We're doing this to help make the epidemic stop.
Hi, Esther.
Yeah.
Sorry, it's Nicole here. Are you able to just speak a little bit slower for folks who are? Thank you. Thank you so much.
I get faster and faster.
No worries. Thank you so much.
Yeah, absolutely. Sorry, I can't see the comments when I'm speaking, so fair enough.
All good.
Yeah, thank you guys for reminding me. I also have, you know, a very thick American accent, which is not helpful. So I will say one of our successes, and this is a local success, so I live in Boston, Massachusetts, and one of our successes, I think, in speaking to the press early and often about what we were seeing is that we've actually managed to change the testing criteria. So this was just issued on May 13th, and COVID toes or pernio-like lesions of the feet are now considered testing criteria for COVID-19. So we've actually managed to change a lot of the testing criteria around us because of our, you know, discussions with the media and sharing of our early data. So I think that's important to do. So I wanted to talk a little bit about what we are seeing in the registry itself. And we're really seeing a wide range of skin manifestations. And I realize that I'm speaking to a room of patient advocates and not necessarily of dermatologists, but I thought it was important to still share with you some of these skin conditions. And I'll also show you a couple of pictures of each of them, just so you can kind of get a sense of what we're seeing. So the first one that people are hearing about is something we're calling COVID toes, which are these pernio-like lesions of the hands and the feet. And I'll talk to you about those in a minute. So this is just a picture of the different range of different skin conditions we're seeing. And I'm going to go through these one by one. So the first one is toes. I'm seeing many, many, many toes. Most of the toes I'm seeing are not happy toes like these toes. They are more unhappy toes. And I wanted to give you a couple of pictures of what we're seeing with these quote unquote COVID toes. So these are what we call pernio-like lesions of the feet. Pernio is normally a condition, if you think about pre-COVID times, where it's a reaction to cold temperatures. So you can get red or purple lesions of the toes in reaction to exposure to the cold. It's a little different than frostbite. Frostbite, you actually get direct tissue injury, so your tissue is actually frozen. Here, your skin isn't actually frozen, but it creates like this inflammatory response to cold temperatures. And it can look like this. It can be purple, it can be swollen, it can be tender. Unusually, we're seeing this in COVID patients with known COVID-19, and we're also seeing this in patients where they live in warm places, and so you wouldn't think they would be getting this kind of reaction this time of year. We normally see it in winter, maybe a little bit in early spring, but it would be unusual for us to see it as it warms up and in warmer climates. So I think the most important thing to know about these lesions is that our patients who have the COVID toes or the pernio-like lesions of their feet are really doing exceptionally well. Very few of them are admitted to the hospital. We've not had a lot of severe pulmonary or respiratory disease in our patients with these toe lesions. And so really we're discouraging patients from rushing into the emergency room unless they have something else going on and some other reason. So I would encourage you to reach out if you do develop these lesions, to reach out to either your dermatologist or your primary care doctor and discuss the lesions and discuss the plan from there. They may encourage a COVID test for you. And certainly they would discuss isolation practices. I think the other thing it's important to know is that many patients are developing these toe-like lesions significantly after their COVID infection. So many patients are getting COVID and then they're developing the toe lesions 2, 3, 4 weeks later. So I don't want people to get the impression that if your toes turn purple, something horrible is going to happen to you and that you're going to get really sick. In most cases, people are actually getting this almost like a post-viral response. So they're seeing it after the infection. So certainly if you develop them, it could mean that you've had the infection in the past. There's other reasons for your toes to be purple, which is why I think it's important to discuss with your healthcare provider, just to make sure that there's nothing else going on. And I will point out that COVID toes are not just toes. We also see these on the fingers as well. So here are a couple of different examples of what we can see on the hands. And I would say about a third of our patients who have it on the toes also have it on their hands, but very few, only about 5 to 10% get it just on their hands. So primarily involves the feet, but not only. I think people really want to know why this is happening. And I actually thought this is a really nice article in USA Today, written for a lay audience. So I think it would be great for patients and patient organizations. And it's a nice overview of how the immune system can react to the virus. And I thought what was nice is they did a nice infographic. Again, this is really aimed at the general public for how immune cells called lymphocytes can travel into the skin and cause inflammation, which is what we're seeing in the tissue. And I also want to be reassuring. I think people are really worried about the concept of clots because we're hearing that patients with COVID-19 are having strokes and are developing clots and other tissues. I want to reassure you that when we see these perennial-like lesions of the feet, the purple lesions, those are not clots. Those are inflammation, and that does not mean that you're clotting elsewhere in your body. There are some other dermatologic manifestations that are from clots, but these are not one of them. So there's a really nice paper, if you were going to read one piece of medical literature on dermatologic manifestations of COVID-19, this paper from Spain, studied, published by the British Journal of Dermatology, is a really nice overview of the cases that they were seeing. So I wanted to go through some of the other rashes we're seeing. This is called a morbilliform eruption. It's a non-specific viral rash that we can see really all over the body. This is basically a rash that can look like chicken pox. So this is chicken pox or varicella, can also look like shingles. So these are little vesicles that are little fluid-filled bumps on the skin. And we've seen this in patients as well. We're also seeing hives, also known as urticaria, which you might normally see in an allergic reaction, but we're also seeing these as a reaction to the virus. And this is a very intensely itchy process. This is a little bit more non-specific. Macular erythema is just basically the skin turning a little bit pink or red and being a little bit patchy. And then this is something else that we're seeing on the legs, and we can also see it on the arms. The technical name for this is Libido reticularis. Reticularis means net-like, and it's basically this net-like pattern. And it, normally if you got really cold, you might see this normally on your skin, but you would see it symmetrically. So if I got really cold right now, and I looked at my thighs, I would probably see a faint net-like pattern on my thighs anyway, just because of the way that our blood flow works. But in this condition, we're seeing it just on one side. And this may be caused by little microclots, little clots in the system, which is different than the toe lesions that I was talking about. So your dermatologist can report your case. So if you believe that you are experiencing a cutaneous manifestation of COVID-19, you yourself cannot put your own data in. And if you do, we actually just remove that immediately from the registry. But your dermatologist can put your case in, and not just your dermatologist. The case reporting system is open to any healthcare provider worldwide. So if you saw your primary care doctor through telemedicine, they can put your case in as well, and certainly encourage them to do so. Case entry only takes about 5 to 7 minutes, and it's non-identifiable. So they're not going to put in your name or where you live other than the country. And so we won't be able to tell that it's you. So we don't collect any protected health information. The last thing I wanted to talk about, which is a little bit of a change from the registry, is just to talk about the fact that a lot of our behaviors are changing in the face of COVID. And I know a lot of my patients are struggling with having allergic contact dermatitis or irritant dermatitis or rashes of their hands from the frequent hand washing. And so I did want to mention that the American Academy of Dermatology has come out with guidance on how to protect yourself. And I think really, moisturization is the key, really frequently moisturizing your hands, but it's tough. And this is definitely something you can talk to your dermatologist about as well. And certainly an issue that we're seeing. And I think as people start to return to work, we're going to be seeing this a lot as well. So I wanted to kind of remind everyone of this quote from my dad, which is that, for all of us, which is when confronted with an outbreak, your job is to make it stop. And for you, maybe that means wearing a mask. Maybe it means staying home. Maybe it means reporting your case. Maybe it means getting tested. So I just think if you kind of use this as a guiding principle, it won't steer you wrong. And so my many thanks to the American Academy of Dermatology COVID-19 Task Force. Our membership is spread all across the US. And of course to the International League of Dermatologic Societies for their incredible support of this process. And in particular, Lars French and Henry Lim, who have really been absolutely instrumental in creating and supporting the registry. And I would be remiss to say if we didn't talk about the next generation of dermatologists. So my research fellow, Devin McMahon, who is a Harvard Medical School student who's helped with a lot of these analyses. Thank you very much. I'm sorry for speaking so quickly.
Not a problem at all. Thank you, Esther. I can go ahead.
So are we moving into the question period now?
Yes, sure. I was just going to say, Esther, you can take off your screen if you'd like.
Sure.
And
Yeah.
Hi, everyone. Yes, now we'll be moving into the discussion period. So we already have one question from Rachel Mannion here for you, Dr. Freeman. And the question is, in the case of COVID toes, is it also the same for children who have
Yes.
COVID?
Yeah, so we are seeing COVID toes both in our kids and in our adults. So through the full range of age spectrum. I have kids as young as 10, but I also have adults as old as 90 who have developed this. So really the full age range. I think some of the original reports were that it was primarily in kids. I haven't really seen that to be the case. I've really seen it in everyone. I think perhaps what's been surprising is because kids and young adults don't necessarily get other manifestations of COVID. I think it was a little surprising to people that they were developing these manifestations.
Thank you.
So,
go ahead, Christine.
Thanks. So I have a question. Since I think virtually everyone that's on the call today, Esther, is a leader of a patient organization. Is there something that patient organizations around the world can do to promote use of the registry, the global registry? And I'm just thinking specifically that if we were to send out something that everyone can post on their website that encourages the patients that come to their websites, that if they find that they've got manifestations, cutaneous manifestations of COVID, that they ask their doctor to make sure that their case gets registered. Is that something that you would encourage us to do?
Yeah, I think it's really important that people know that it's really only provider entered. It's actually very challenging for us when we have patients entering their own cases because it requires a lot of work on our end to remove all of those cases. And because they're not covered by our ethics review, we are required to remove them. So it's really important that people understand that we don't want them to pretend to be a medical professional and put in their own data. And so I think as long as it was extremely clear that it's really about advocating to your healthcare provider to enter your data for you, I think that would be fine.
So
I say that with the caveat because we're the ones on the other end that are struggling a little bit when patients put their own information in. And I totally get the desire to put your own information in. The questions that we ask are really very specific to healthcare providers. So I think as long as there was an understanding that it was really about advocating for you or your case to be included, then we would love to have those cases.
And I guess the other question that's probably out there is, and this is sort of on the other side, are people with dermatological conditions, do we think that they may have additional risks because of their dermatological conditions with respect to COVID-19? So would someone with a skin disease or any kind of cutaneous disease have additional risk, and would they be considered in that high risk profile? And are there diseases for which that's true and some for which it's not?
Yeah, that's such a great question, Christine. And in some ways answerable, in some ways unanswerable. I think that one question that's really come up is our patients who have, for example, severe psoriasis or severe eczema, and they might be on an immunosuppressive medication. So they might be on a biologic medication, they might be on methotrexate, something like that. And so some of our more strong, I would say, dermatology medications are definitely a concern. And there's been a lot of guidance from different international societies. The American Academy of Dermatology has guidance on use of immunosuppressive agents during COVID-19. And a lot of National Psoriasis Foundation. The rheumatology group has been working really a lot on this. And I will say that a lot of the data has actually been pretty reassuring, which is great. So the Global Rheumatology Alliance is about to come out with a paper about this, and I think overall pretty reassuring about our patients who are on biologics. Right now, what we do recommend is if you are on an immunosuppressive medication, that you would certainly have a case-by-case discussion with your doctor, because there's a lot of decision that goes into deciding if you're going to come off the medication or stay on the medication during this time. Your doctor would discuss with you your other problems that you might be having. So are you otherwise in a high-risk group? Do you have cancer? Are you over the age of 60? Are you a smoker? All of these things. Do you have a history of lung disease? All of these things would probably play into that discussion with your doctor. And also, what was the original reason that you were on the medication? Did you have a small amount of psoriasis? And so maybe taking you off is not going to cause a huge problem. Or did you have a really big amount of psoriasis and taking you off of that medication is going to land you in the emergency department? It's a very different conversation. So I don't think there's a one-size-fits-all approach to this, but I think it's important to be aware. And I will say there's other conditions as well beyond psoriasis. So for example, a lot of my patients early on who had either acne or rosacea or perioral dermatitis, and were on a medication called spironolactone to treat that. There was some concern early on that could increase the risk of COVID. And I don't think that's been shown to be true. And so I've counseled my patients to stay on that medication, but I think it's challenging. We're in what I would call a data-free zone for many of these things.
Yeah. And so the notion of so the general guidance is that the notion of comorbidities, and I see Larry is popping up with some chat there. The notion that if you're over a certain age and you've got comorbidities, that you're at higher risk, but we don't know at this point whether or not someone with, say, a rare dermatological condition or something with open lesions, like HS or pemphigus or any of the.
We don't truly know if we don't really have reason to believe that the skin condition itself would necessarily lead to increased risk, but I think a lot of the comorbidities that can travel with a skin condition could. So I think that's a really important question. And I do see, Dr. Bott, that you had a question that I would love to answer as well. Did you want to ask that out loud?
Yeah, how to go to the EAD registry, because we have to be members of EAD. Of course, I'm a member. Others, whether it is required that only members can enter or any dermatologist can enter this COVID registry.
Great question. So not even any dermatologist, any healthcare provider worldwide, from any country and any specialty, you don't need to be an AAD member. And the website for I can post it again in the chat. The website happens to be sitting at the AAD just to give it a place to sit. But the data is not even housed at the American Academy of Dermatology. So the American Academy of Dermatology is helping facilitate it, but the data is actually housed securely at my home institution, which is Massachusetts General Hospital at Harvard Medical School. And so it's definitely not just for AAD members. And so I thank you for bringing that up, because I think people get the impression that might be the case. And it's really important to know that this is actually an International League of Dermatology Societies registry as well. And so it's really open to all of our partner organizations. So don't let the AAD website dissuade you. And then I think someone asked, Cicely, I believe, asked about testing criteria for COVID-19 and also duplicity of data. These are both really great questions. So there is not totally agreed upon testing criteria for COVID, I would say, anywhere in the world. Part of this might be due to the fact that it's changing so quickly. The U.S. Centers for Disease Control changes its testing criteria pretty much once a week. And here, for example, at Harvard Medical School, we have our own testing criteria that's really informed by the local situation, which also changes every couple of days. So I don't think there's a universal gold standard. And I think there's a lot of variability. So I would just say that encouraging people in your local area to recognize the fact that skin can be a manifestation of COVID-19 or a symptom of COVID-19 is helpful. I think the other question you asked, which is great, which is how do we avoid duplicates? So your question is, if you see a patient with a skin manifestation and your colleague then also sees the same patient with the same skin finding, or they might see their ER doctor with the same skin finding. So we do check for this. So we have enough patient details. We can't identify the patient, so it can never be 100% sure, but we do check if a patient from the same location with the same age and the same gender and the same skin finding has seen multiple providers. We do get in touch with the providers to make sure that that's not the same person. So we do actually check for that, but that's a really great question.
I think we have Rachel also who wanted to ask another question.
Yeah, hi. Thanks very much for the presentation. This has been really, really informative, Dr. Freeman. I'm curious about whether the dermatological manifestations of COVID in children in the pediatric context might be a bit different. And that was sort of the genesis of my question about COVID toes. And so I'm curious about the impact of COVID in children and what we're seeing from a dermatological perspective. And I'm also curious to see how much of the data that's being collected in registries actually reflects the pediatric context.
Great question. Yes. So a couple of thoughts on that. We have seen some unique manifestations in kids. So certainly these pernio-like lesions or COVID toes was, as I said early on, reported in kids. And the other thing now, of course, is most recently, just in the last few weeks, is this Kawasaki disease-like syndrome in kids, which is a new name, which is I'm going to get it wrong without looking at it, multi-inflammatory immune response, something. It's MIC-C.
Multisystemic something, yeah.
Thank you. Multisystemic, I can't look at it without it in front of me.
Inflammatory.
Thank you. The CDC renamed it like this week. I've written it down like 5 times, but it's hard to remember the full name. So this is a syndrome where kids can get fever, and they can get rash, and they can get really inflammation in a lot of different organ systems. I will tell you, this is scary to me. It seems to be, thankfully, still somewhat rare, but it's happening. And, as a mom of a 3- and 4-year-old, I don't find this information particularly reassuring. I do think that dermatologists can be helpful here as well, because, we are very attuned to what rashes can look like. So I think that's another important way that we can be involved. In terms of capturing data on kids. great question. So the Pediatric Research Alliance, which is called PEDRA, has its own registry, which I think was on my registry slide where I listed many registries. They have one specifically for the Pernio-like lesions in children. In our own registry, we also collect, in the ILDS and AAD registry, we also collect pediatric data. I will tell you about 25% of our data that's entered is in children.
Wow.
To give you a sense, and that's not for everything. It's about 25% of the data on Pernio, at least, is in kids. I think kids are going to be less well represented in the other rashes because I think they're just not getting them as much. So we do have a pretty robust pediatric data set, but I think combining forces with the pediatric team as well will give us even better, better sense. But it's a great question, and I think maybe also what your question is getting at is the pathophysiology in kids. And I do think that kids are reacting differently. We're seeing that they're reacting differently than adults are to these, to these conditions for sure. Let's see if I can.
If there's any more questions from folks, or if you'd even like to unmute yourself and show your video, we'd love to have a fruitful discussion. So please feel free to speak up.
I think there's one on the chat, Nicole, from Sicily. Do you see that one?
I believe that Dr. Freeman already addressed the two questions.
Okay, apologies.
No worries. I see here that Professor Boroduri did like the suggestion of Christine to advise all patients and POs to ask their physicians in the case of COVID-19 infection. Yeah.
And I would also like to highlight just the incredible role that patients themselves and all of you play in all of this. I think that, if people hadn't started going into their healthcare providers with these unusual, findings, I don't think we would be aware of this. And I know that in the United States, and I don't know how international this is, something called Survivor Corps, which is like an international, or at least national group. I believe it's on Facebook or on social media, of people who have had COVID-19 and are kind of sharing patients and are sharing information directly with one another. And I think that patient voices can be a really important, critical part of this in really recognizing what's happening and building, provider knowledge. Early on, I had a lot of patients come to me where they said, I've been to, before we did a lot of information about COVID toes, patients said, I went to my doctor like 4 times, and they just told me that it was, that it was like my shoes or something else. And so I think it really took a lot of persistence on people's parts to say, something is really, this is not normal for me. Something is really going on. So, a huge amount of respect to our patients for navigating what can sometimes be an unfriendly system.
Well, we do know, we've heard through a questionnaire that we put out to our member organizations that the results of that showed that they are considerably busier because I think it is that patients can't go and see their doctors or aren't in the height of the epidemic in their country able to go and see their own doctor or their own dermatologist, or they had an appointment scheduled, so they are contacting the patient organizations directly about their condition, their underlying dermatological condition. So it may not have anything to do with COVID, but the fact is that our members are busier at this point, and show there are lots and lots, I think, more points of contact than there might have been in pre-COVID times.
Mm-hmm. And how we seek care has changed. I know I'm seeing a lot of patients virtually, which is not my normal practice. And it's very different. I think it's very different for all of us to get used to on both the patient and the provider side of how in some ways we're more accessible, in some ways we're less accessible. So it's very different times. Yeah. I did see, I think another question.
I have a question.
Yeah.
Do you hear me?
Yes.
Dear Esther, so I would like, so it's Luca Boroduri from Bern.
Hi,
Esther,
Luca.
I would like to thank you for your very important initiatives. I would like to thank you and say you a great job for your presentation. And I would also say that your father would be surely very proud of you because now when he said when confronted with an outbreak, your job is to make it stop. I think that by your current work and by making people more familiar with the manifestation of the disease, you directly contribute to this take-home message you receive from your father. So this is great. I have a question concerning skin manifestation. Since I made most of my teaching, our education in France, I have a good exchange with my French colleagues from in France. They have indicated cases of people having skin lesions affecting specifically the face. Do you have also these cases where people have a kind of acute lupus or a kind of erythema-like lesions of the face affecting predominantly the face or not?
Oh, that's interesting. I hadn't heard that yet. This virus continues to surprise me.
Yes.
In some ways, I'm not surprised to hear of something else that surprises me because I feel like every day I am surprised by something. We do have cases in the registry where we're seeing rashes appear on the face, but I've not seen as much predominantly the face. And now that you mentioned that, I'm going to go back and look. What we have seen in morbilliform rashes, which are these kind of non-specific viral rashes, in about 10% of our cases, we are seeing them appear also on the face, which is interesting because in viruses, you can expect to see them potentially on the face, but not all that commonly. And in drug-induced, so a lot of people ask, oh, is it possible it's just the medications, it's not the virus? In drug, unless you have a really, really severe reaction, we wouldn't normally see the morbilliform on the face. So I think that's interesting. But now you've inspired me to go back and look in our data at people where it was just the face. So these are people where it's just on the face?
Yes, and they also insist about erythema nodosum, this kind of more panicolitis changes. So these are the unofficial feedbacks I get from French colleagues.
Well, thank you. This is how it starts. I mean, I remember super clearly this is such an interesting way for data exchange to happen because I think that it's not happening necessarily through papers, it's happening through social media and through conversations.
Yes.
Because it's happening so quickly. I remember super clearly we had started the registry already before the first cases were reported of the pernio-like lesions or the COVID toes. We were already building the database and we were coding the different rashes that we might see. And someone called me and said, I have a case of pernio. And I said, well, add it to the list. And little did I know that was then going to be most of what we were seeing. So I thank you for that. It's going to make me go look back at our data and see. I hadn't looked at just the face, so I will.
Can I just ask a question? Are those on confirmed COVID cases?
In France, yes.
Okay.
But Esther, just for everybody, so I know that at the moment the relationship between the United States and China is not the best ones. But we had the opportunity to have contact with Chinese dermatologists, including the president of the Chinese Society of Dermatology. And very interestingly, the Chinese dermatologist did not report at all skin manifestation as something important. So, or they saw so many severely ill patients, they did not care about skin. But when they were asked about, did you see anything specific? The answer was almost invariably, not really. We did not see nothing special.
Yeah,
so this is
interesting that you bring that up. So we've been in touch with the president of the Chinese Derm Society, I think probably as have you, and we've actually invited them to participate. They've actually posted the registry on their website for our dermatology colleagues in China. And interestingly, the last time I checked, we had exactly 3 Out of like over 100 and like 750, we have 3 cases from China. So
it's impressive, yeah.
Yeah, and I don't, and it doesn't, I don't think it's from lack of interest. Honestly, seeing something, it's different.
Different, yeah. Mm-hmm.
Yeah, I think it's different. And there's so much left to be learned about the virus.
Yeah,
I don't know why. I don't know why. So that's a really interesting point. Yeah, it was, I remember thinking at the very, and I'll stop saying that, but at the very beginning of the epidemic, I remember thinking to myself as our hospital, Massachusetts General Hospital, which has been hit very hard by COVID-19, and our department was redeployed. So that means that we were taken out of dermatology and my colleagues were put into the respiratory clinic, which I know is the case for many dermatologists in Italy and France and Spain. And I remember thinking to myself as we put a tent in the front yard of Mass General, and we put a testing center in our garage. And I remember thinking to myself, oh, wow, this was very early on. I remember thinking, oh, it's a good thing that COVID doesn't present with a rash, because if it did, I would be in the testing tent 24 hours a day. This was very early on, and I was, how wrong was I? So.
Just for everyone on the call, we'd love for folks to start sharing their videos and also unmuting their microphones if they have a question, so we can see everyone's lovely faces on this call, if you're comfortable, of course.
And a quick answer to Dr. Bott's question about hydroxychloroquine prophylaxis. So I think the data increasingly is coming out that Plaquenil or hydroxychloroquine is not that helpful. So I certainly don't recommend it as prophylaxis, despite the fact that the American president seems to be doing that. It's not something I will try to remain apolitical, but it's not something I recommend.
I think we have one more question from Masanori. Why does COVID-19 present skin symptoms like COVID toe?
So I think it all relates to the massive inflammation that this virus is causing. And it's so fascinating because we're seeing inflammation in so many different parts of the body, in so many different tissues, in the lungs, we're seeing it in blood vessels, we're seeing it now in skin. And so I think a lot of it has to do with the inflammation that it's triggering in the body, and it's presenting it in so many different ways.
Thanks. Also, if Dr. Bod and Professor Borger, if you have anything else to share with us here, or if there are other patient organization leaders who'd love to speak up, we'd love to hear from you.
Thank you. It was a nice presentation, and we are also observing the same manifestations, whatever you have mentioned, but for this COVID toes, because the temperature is quite warm here, and we are seeing lots of urticaria cases and then exanthems, but COVID toes not many. And we have initiated COVID registry in our website also. I think once we get enough cases, we'll forward it to ILDS registry also.
Yeah, please. We would love to collaborate. And we have a place at the end of our registry where you can also indicate if you've entered the case into another registry. So we have that right now for the French registry, but we'd be more than happy to add your country as well.
I believe we have Bernd.
Yes, thank you very much, Professor Freeman, for your excellent presentation, and honored to be on the call with all many esteemed colleagues and also my colleague patient leaders. I'm a patient advocate from Amsterdam, the Netherlands, but I'm also a member of the steering group of Secure AD as a patient representative.
Oh, great.
With Professor Floor and Phyllis Pulse. And I'm sorry to interrupt, but I want to, the patient reported, patient-facing registries are underway. Psoriasis Protect Me is live. Secure AD patient-facing is going to be live soon. And I would encourage all patient organizations who are present here to go to there's an excellent resource page on the GlobalSkin webpage on COVID-19. It also mentions, of course, the provider registered registries, but also the one for the patients. And in order for patients to fill in data that is going to be complementary to the healthcare provider data, I would very much like to encourage patient leaders and patient organizations to check if it's already live, and if and to promote the patient one, as you said, because you don't want to clutter the data or from the healthcare professional ones. We're in the midst of finalizing also a very simple patient summary on the Secure AD and the Secure AD patient-facing registries. Very simple language, and maybe the other ones could use it or translate it in their for their specific region. But I would like very much emphasize, and that's also why it's so great that you as healthcare professionals are here in the call from the patient organization. It's going to be a joint success. And we need the data from both sides. And also in the Netherlands, we not advocate people to put their data in the register for healthcare professionals. But we say, if you suspect you had COVID, please talk to your dermatologist and ask them, because not all dermatologists are aware that it's up and running and can be used worldwide. So thank you very much for the opportunity to relay this message to all of you. And thank you very much for all your efforts, and very impressed. Thank you.
Thank you, Bernd.
Bernd, thank you so much. I think that's so important. And I will add also to your list, in addition to psoriasis and atopic, also hidradenitis suppurativa also has a patient-facing registry as well.
Okay, yes.
I think alopecia might be working on it. I don't know about that one.
Working, yes. Yeah. We're all very busy, yes.
Yeah, I'm sure. What a huge effort. And I will say it's so interesting. I would check out, if you haven't already, the International Rheumatology Alliance.
Yes.
And
they have two. Yes, they have two.
Yeah,
One, yeah.
They provider and patient. And
Yes.
I think it's been very fascinating to me to watch their numbers go up and to see the different numbers of patient-reported cases versus provider-reported cases. I think is really interesting. And
Yes, are a great example. Yes, yeah, a great example. They're leading the way in the case.
Yeah.
Yes. Thank
So
you.
I realize also that we are now at 11:07. So thank you to everyone for staying onto the call and being a part of our webinar today. So I think maybe what we can do is, for folks who don't have their videos on, you can turn them on now for the group photo if you feel comfortable. And maybe someone, Vishnu or someone else, can take a group photo for us, if that's okay. And just let us know when to smile and wave.
Vishnu, are you going to be able to do that? Yeah. So, okay. Here we go. Hi, Julie, we can't hear you. I can see your lips moving, but I can't hear you.
I was trying. I just can't do it. It's too early. I'm sorry. Love you all.
Okay. No worries.
No, you look great. No, come on, put your face back up. You look great.
Oh, Lordy.
Come on, you look great. Thank you. You look fine.
Amazing.
This is not like, going to go on national TV or anything. So we promise. So we're still waiting on a few. Laurence, I think. Masanori.
Bernd says no camera. That's okay.
Yeah, no, I heard that.
It's so nice to see all of you guys.
Mm-hmm.
Yeah.
Great. We've had a few fall off, okay. Gary. I'm trying.
There we go. Lawrence, I'll try for.
Looks great. All right, everybody.
Oh, we've got Gary. Good.
Oh.
Okay, she found it.
I think just Trong and Oliver.
Yeah. Okay.
Oh.
Oliver. Yeah. Oliver. Or is it Oliver? Or
there we go. There we go.
Okay.
We're all here.
Okay, we've got as many.
Perfect. Thanks, everybody.
Thank you, everybody. It was a great afternoon for me. And thank you, Esther, Christine, Nicole, Ramesh. So everybody for this great
yes.
opportunity, really.
Yeah.
Thank you.
Merci.
And I also want to give a special thank you to Dr. Esther Freeman who spent a lot of time putting this together, and for all of you for joining us. I think we'll send out, we'll look at putting something together about the registry that potentially you can all share on your websites with some clear language. So thank you very much, and I wish you a good evening, a good morning, a good afternoon, and we look forward to seeing you all in the next town hall that we do.
Thank you. Thank you very much.
Thank you.
Thank you.
Thanks so much.
Take care. All the best to you all.
Thank you for the
Bye,
opportunity.
everybody.
Bye-bye.
Bye.